Our mission for this deep dive isn't to quiz you, but really to serve as your expert guides. We need to distill this sophisticated system, this remarkable interplay of bones, the complex joint network, the specialized 20 muscles, and the absolutely vital neurovascular lifelines
All of it.
into a narrative that is both understandable and critically memorable for you, the learner.
Because when you just look at the forearm, it seems like a simple connection, between the shoulder and the hand. But internally, it's just a master class in compartmentalized efficiency. It's a system designed for both immense power and the most delicate precision.
It truly is precision engineering. I mean, think about this for a second. Despite its relatively small real estate, this region houses 20 distinct muscles, all tucked into two primary fascial compartments.
20. That's incredible.
It is. And it contains three major arteries, the radial, ulnar, and interosseous, and four crucial nerves. That kind of packing efficiency and, functional separation, it just demands meticulous attention to detail as we explore it.
So we're going to build our understanding logically, layer by layer, starting from the outside and working our way in.
Makes sense.
We'll begin with the superficial tissues and the architectural framework, move to the bones, then discuss the incredible joint articulations, analyze the powerful muscle groups, and finally, trace those essential vessels and nerves.
So we're performing a methodical unwrapping, really identifying every crucial component along the way.
Okay, let's unpack this. Starting with the very surface. The skin, soft tissues, and the crucial blood supply that feeds them.
Right at the top.
When you observe the skin over your elbow and forearm, you might not immediately realize how intensely supplied it is, especially by blood. The cutaneous vascular supply forms this dense, almost redundant plexus.
And that redundancy is absolutely vital.
Why is that?
Well, because this entire region, particularly the elbow, undergoes massive changes in geometry and position. Think about it. Blood flow has to remain robust whether your arm is hanging relaxed or your elbow is maximally flexed, pinching everything in the crease.
Okay, so this is where we see that magnificent coordination of the collateral vessels you hear about.
This is exactly it. That dense plexus is fundamentally derived from three main arterial sources: the musculocutaneous, the posterior antebrachial cubital, and the antebrachial interosseous arteries. It's a three-pronged attack, so to speak.
A three-pronged attack. I like that. So where do they come from, specifically, let's say, around the front of the elbow?
Okay, so for instance, the vascular network supplying the skin around the anterolateral cubital fossa, that's the front, and the outside of the elbow, is fed by the radial recurrent and the anterior ulnar recurrent arteries.
So we're talking about a kind of arterial road network with multiple detours and bypasses built right in.
That's a perfect analogy. And if we follow that network to the posterior cubital fossa, the back of the elbow, the supply there comes from smaller direct branches of the brachial artery itself.
The main highway.
The main highway, yeah. But also contributions from the radial recurrent and the posterior interosseous recurrent arteries. The sheer redundancy of this collateral supply around the elbow joint is a structural guarantee. It's what maintains blood flow and tissue viability during any movement.
Especially high stress or sustained flexion, right? Where that main highway, the brachial artery, could be mechanically compressed.
Precisely. It's an insurance policy. Now, moving distally into the forearm skin and fascia, the anterior and posterior surfaces get their supply primarily from the two main vessels we'll discuss later, the radial and ulnar arteries.
So they feed the muscles deep down, but also send branches up to the skin.
Exactly. The radial artery supplies the anterior, dorsal, and palmar carpal branches. The ulnar artery contributes its anterior and posterior ulnar recurrent arteries, along with a palmar carpal branch of its own.
And this highlights the incredible specialized role of perforators. We need to emphasize this point because the skin isn't just passively fed, it has dedicated supply lines.
It absolutely does. We're talking about musculocutaneous and septocutaneous perforators that originate directly from the main radial, ulnar, and interosseous artery.
So they literally pierce through the muscle to get to the surface.
They pierce through the deep fascia and muscles specifically to ensure that the skin, which is our largest organ, after all, has its own robust, dedicated microcirculation.
And as we track toward the wrist, does that pattern continue?
It does. The distal third of the forearm is heavily reliant on the radial artery, particularly along its lateral edge, running right alongside the extensor digitorum tendons.
Okay.
And on the posterior side, the interosseous arteries continue their supply, passing through the deep intermuscular fascia to merge with the posterior carpal network. This ensures that the back of the wrist, which is so crucial for extensor tendon function, is really well nourished.
So the arteries are the fuel lines. Who are the control wires? We need to map out the cutaneous innervation. Who is sensing the surface of the forearm?
Okay, so we have three major sensory zones here. It's a nice, clean division. Let's start with the medial side.
The inside of the arm.
The inside, yeah. The anteromedial and posteromedial skin are innervated by the medial cutaneous nerve of the forearm. This is a sizable territory covering the skin from the elbow right down to the wrist.
How much of the forearm are we talking about?
Roughly the entire ulnar quarter of both the anterior and posterior forearm surfaces. So think of the strip of skin along your pinky side.
Got it. So that entire medial strip is covered by one nerve. What happens when we shift to the lateral boundary, the thumb side?
The anterolateral skin, so the outer front edge, is innervated by the lateral cutaneous nerve of the forearm. And here's an important distinction.
Go.
This nerve is actually the terminal part of the musculocutaneous nerve.
Which we know from the upper arm, right? Biceps brachialis.
Exactly. It's best known for supplying those big flexor muscles in the arm, but it finishes its course as a sensory specialist in the forearm. It changes jobs.
Fascinating. And finally, the large expanse of the posterior surface, the entire back of the forearm.
That whole region is handled by the posterior cutaneous nerve of the forearm, which is a key branch of the radial nerve.
The big extensor nerve.
A big one. So if you feel a specific sensory change, say numbness or heightened sensitivity on the back of your forearm, that strongly points to an issue somewhere along the radial nerve pathway. We have this perfect anatomical map based on the sensory distribution of these three nerves, all originating from the brachial plexus.
That structural map leads us right to the critical architectural organization beneath the skin. The forearm muscles aren't just a loose bundle. They are rigidly organized by fascia.
And this is vital, not just for muscle power, but as we'll see, for clinical reasons too.
So let's talk about this deep fascia.
We have to highlight the deep fascia, which is known as the antebrachial fascia. Now, this isn't just a thin covering like plastic wrap. It's a dense, strong, enveloping sheath that fully contains all 20 muscles.
And it anchors somewhere, right? It doesn't just float.
No, it attaches firmly to the rigid parts of the ulna, specifically the olecranon, that bony point of your elbow, and the entire posterior border of the ulna. It's tacked down securely.
And it's this density that really defines the functional limits of the forearm. This deep fascia works with two other internal structures to create the essential compartmentalization.
Precisely. The deep fascia, along with the interosseous membrane, that sheet of tissue connecting the two bones, and the fibrous intermuscular septa.
So walls of connective tissue.
Exactly, these internal walls. Collectively, they divide the forearm into its two fundamental, functionally specialized compartments.
Okay, let's name them and define their purpose. We have the anterior compartment, the flexor pronator compartment.
This is the compartment of action. This is your power zone, responsible for grasping, lifting, and turning the palm down. It houses all the primary flexor muscles and their tendons.
And what else is in there?
Crucially, this compartment contains the median nerve and the ulnar vessels and nerve. It's densely packed.
And then the counterforce, the posterior compartment, the extensor supinator compartment.
This compartment provides the control and release. It manages wrist and finger extension and the powerful movement of turning the palm up supination.
And what's packed in there?
It contains all the extensor muscles, branches of the radial nerve, specifically the deep branch, which becomes the posterior interosseous nerve and the posterior interosseous vessels.
This tight, compartmentalized architecture is one of the most elegant solutions for combining power and structure, but it also introduces an immediate risk.
A huge risk.
And this is where we bring in the clinical correlate, compartment syndrome.
It's the cost of efficiency. Because that deep fascia is so rigid and non-yielding, if there is major trauma, a crush injury, swelling, or internal bleeding, a hematoma, the pressure inside these compartments has nowhere to go.
It just builds and builds.
It rises rapidly to the point where it can occlude the blood vessels and crush the nerves within, leading to acute ischemia. This is a surgical emergency.
An emergency because if left untreated,
it leads to irreversible muscle and nerve damage. The system designed for strength becomes fatally vulnerable under extreme internal pressure.
Okay, to understand the movements of pronation, supination, and flexion, we absolutely must start with the immovable platform and the mobile components. We're diving into the bones, beginning with the distal humerus, which acts as the complex pivot point for the entire operation.
It's the keystone. If you imagine the humerus distally, it's best described as a modified condyle. What that means is it is not uniformly shaped. It is dramatically wider transversely than it is anteroposteriorly.
So it's wider side to side than front to back.
Much wider. And this creates a broad, stable base that simultaneously dictates the movement of both the radius and the ulna.
This condyle features two highly specialized articular surfaces. Let's start with the structure that really defines the stability of the elbow, the trochlea.
The trochlea is architecturally fascinating. It's shaped like a spool or a pulley. It's convex on the front, concave on the bottom, and it articulates perfectly with the deep C-shaped trochlear notch of the ulna.
And that perfect fit is what gives us the hinge.
That fit is what creates the pure hinge mechanism of the elbow. But here's the key functional insight. The trochlea is not symmetrical. Its medial margin projects slightly more distally than the lateral side.
So it's tilted a bit. Why does that matter functionally?
That slight lateral to medial tilt is what determines the axis of movement and, consequently, the carrying angle. When the elbow is extended, that tilt ensures the forearm projects slightly laterally, away from your body. This allows the forearm to clear the hips when you're walking or carrying an object. It's a subtle but essential biomechanical adaptation.
But it's not a design flaw, it's a feature.
Absolutely a feature. Now, lateral to that stable trochlea, we have the second surface, the capitulum.
Capitulum.
The capitulum is a smooth, rounded head, specifically designed to articulate with the disc-like head of the radius. But here's a surprising little nugget.
The one.
Unlike the trochleana articulation, which is constantly engaged, the radius only fully contacts the capitulum in partial flexion.
Really? So not in full extension?
In full extension, the radial head may actually be slightly separated from the capitulum. This subtle feature plays into the distribution of forces during movement and weight bearing.
Wow. Okay. Beyond the articular surfaces, the humerus provides these critical anchoring points for the forearm musculature, the epicondyles.
Yes, the big bony knobs on either side. The medial epicondyle is the large, palpable prominence on the inside of your elbow. Think of it as the central hub for the flexors.
So a lot attaches there.
A ton. It serves as the common origin point for the superficial group of forearm flexor muscles, as well as the major attachment site for the powerful ulnar collateral ligament and the pronator teres muscle. It's a very high traffic area.
And of course, the medial epicondyle is famous for hosting the ulnar nerve right in the groove behind it, the place we call the funny bone.
Indeed, a very vulnerable spot. Now, the smaller lateral epicondyle is the mirror image on the outside. It serves as the common origin for the extensor muscles and the radial collateral ligament. It's the origin point for extension and supination.
So flexors on the inside, extensors on the outside. A nice simple rule.
A great rule of thumb. Finally, we have the fossae, the depressions that accept the bony components during the extreme ends of the range of motion.
Landing pads.
The landing pads, exactly. The fossa are the negative spaces that define the potential for full movement. Anteriorly, on the front, we have the small coronoid fossa and the radial fossa.
And they receive
the coronoid process of the ulna and the head of the radius, respectively, during maximal flexion.
So when you bend your elbow, all the way.
All the way. And posteriorly, the large olecranon fossa accepts the olecranon process of the ulna during full extension. Without these accommodating depressions, you would just hit a bony block and lose crucial degrees of motion.
Moving on to the receiving end of the joint, let's look at the radius, the bone specifically built for mobility and rotation. It's the satellite dish of the forearm, designed to sweep across a wide arc.
That's a great way to put it. Proximally, it starts with a distinct disc-like head, which is designed to spin. It articulates superiorly with the humerus's capitulum and medially with the ulna's radial notch.
So it connects to both bones.
Both bones. Below this, you have the slight constriction known as the neck, which allows for ligament attachment. And then we have the prominent radial tuberosity, which is the big anchor point for the powerful tendon of the biceps brachii.
Now, the shaft of the radius has a crucial feature for biomechanical stability, the interosseous border.
Yes. The shaft is generally triangular in cross-section, but that border is a sharp, distinct edge running toward the ulna. It serves as the attachment point for the interosseous membrane, which we will soon discuss as a kind of force-transmitting cable.
Okay.
And we also see surface markings for muscles like the pronator teres and supinator all along its length.
Distally, the radius transforms. It gets much broader and flatter, more trapezoidal. Why is that?
That's because it takes on the primary responsibility at the wrist. The distal radius is the major articular player at the wrist joint, engaging with the carpal bones, specifically the scaphoid and lunate.
And what are the key features down there?
Well, you have the lateral projection, the styloid process. Then there's the important palpable landmark on the dorsal surface, the dorsal radial tubercle, also known as Lister's tubercle.
What does that do?
It acts as a guide or a pulley for specific extensor tendons, changing their line of pull. And medially, it features the concave ulnar notch, which forms the articulation point for the distal head of the ulna.
Okay, so now in contrast to the mobile radius, we have the ulna, which serves as the structural clamp and the primary hinge of the elbow. It provides stability and fixes the axis of movement.
It's the anchor. And the proximal ulna structures are monumental for stability. We start with the massive posterior projection, the all-avrocanon. This is the palpable point of your elbow.
The part you lean on.
Exactly. It's critical for elbow extension, locking into the olecranon fossa, and it's the powerful attachment site for the triceps brachii tendon.
And anteriorly, acting as the lower jaw of the clamp, is the coronoid process.
The coronoid process jets forward, accommodating the coronoid fossa during flexion. It also provides important attachment sites for the brachialis, the pronator peres, and the flexor digitorum superficialis.
So these two processes, the olecranon and the coronoid, they frame the defining feature of the proximal ulna, the C-shaped trochlear notch.
That notch is the perfect cartilaginous clamp that grips the humeral trochlea. That's what provides the incredible stability of the hinge joint. It's usually separated internally by a small vertical ridge.
And what about its connection to the radius?
Adjacent to this, on the lateral surface, is the small, concave radial notch, which is designed specifically to accommodate the rotation of the radial head.
So it's a little docking station.
A perfect docking station. And just below the coronoid process is the rough ulnar tuberosity, which is another anchor for the powerful brachialis muscle.
The shaft of the ulna follows a similar pattern to the radius, but its key characteristic seems to be accessibility.
That's a great point. Unlike the radius, which is buried under muscle for much of its length, the ulna's dorsal aspect, its posterior border, is largely subcutaneous.
You can feel it.
You can easily palpate it from the olecranon all the way down to the wrist. This provides a fixed line for surgical access and a clear anatomical landmark for clinicians. It also possesses a sharp interosseous border mirroring the radius for the membrane attachment.
Now, when we move distally, the ulna completely reverses roles compared to the radius. It shrinks.
It does. The distal ulna features the small, rounded head and the medial projection, the styloid process. And here is a fundamental anatomical distinction that must be stressed.
Okay, lay it on us.
The ulnar head does not articulate directly with the carpal bones.
It doesn't touch them at all.
No. It is separated from the carpus by the fibrocartilaginous articular disc of the wrist joint. This means the ulna contributes no direct weight bearing to the hand. Its whole job down there is to provide a pivot point for the radius.
That's a massive point. Now, since the source details this developmental timeline, let's use the ossification history briefly to set up our final thought later. We see a prolonged commitment to stabilizing this region.
That's the critical takeaway. The bones develop from multiple centers, 3 for each bone, but their timing of fusion is really drawn out. The radius's distal center, for example, appears early at 1 to 2 years old, but holds off uniting with the shaft until around age 20.
20 years.
20 years. The ulna's olecranon center joins the shaft earlier, around 14 to 16 years. This multi-stage, decades-long ossification process reveals just how functionally critical this framework is to our development.
Okay, we've established the frame. Now we need to install the engine. But first, let's assemble the structure. The elbow joint is not a simple hinge, it's a composite system.
It is. You have the humerulnar and humeroradial joints, which allow flexion and extension, combined with the proximal radioulnar joint, which introduces rotation.
So it's 3 joints in one capsule.
Essentially, yes. The humerulnar joint gives us that impressive flexion and extension, about 150 degrees of flexion and near 180 degrees of full extension.
Right.
That is the pure hinge.
And the others.
The humeroradial and radioulnar joints layer the rotational accessory movements, pronation and supination, on top of that primary hinge movement.
And that subtle structural detail on the humerus, that tilt we talked about, results in a classic carrying angle.
Correct. Because the trochlea is tilted, when you fully extend your elbow, your forearm naturally deviates laterally. It forms an angle that is typically around 170 degrees.
And that's to clear the hips.
It ensures that objects you carry, like a bucket or a bag, clear your hips. This isn't just an anatomical quirk, it's a functional necessity for bipedal movement.
Let's discuss the scaffolding that holds these two articulations together. The capsule and the synovial membrane.
The fibrous capsule is a broad, thin sheath. It attaches superiorly, encompassing the epicondyles and the edges of those bony fossae we discussed.
So it's like a big sleeve.
A big sleeve, yeah. Inferiorly, it attaches firmly to the ulna's coronoid and olecranon processes, and it wraps around the annular ligament of the radius, which we'll get to. Inside, the synovial membrane lines all the non-articular parts and has folds that fill the spaces, particularly around the radial head.
But the real heroes of stabilization are the ligaments, particularly the ulnar collateral ligament, the UCL. This thing resists massive forces.
The UCL, located medially, is a strong, triangular structure. Its entire purpose is to resist valgus stress.
What's valgus stress?
Forces trying to push the elbow outward away from the body, like in a baseball pitch. It's composed of 3 parts. The anterior band is noted as the strongest and resists stress throughout the entire range of movement.
And the other parts?
The posterior band is the weakest, and the intermediate oblique part extends to the medial margin of the olecranon. Without this structure, powerful throwing or hitting motions would destroy the joint instantly.
The Tommy John ligament.
The very same. Now, on the opposite side, we have the radial collateral ligament, or RCL.
What's its job?
The RCL extends from the lateral epicondyle and blends directly into the annular ligament. While the UCL resists outward forces, the RCL provides stability during rotation and prevents inward or varus stress, ensuring the radial head remains congruent with the capitulum.
Okay, now we must isolate the rotational engine, the proximal radial-ulnar joint.
This is a textbook example of a uniaxial pivot joint. The radial head spins within the concave radial notch of the ulna. This joint's sole purpose is to facilitate pronation and supination movements.
And the ulna stays put.
The ulna remains essentially fixed and the radius rotates around it.
And the structure maintaining the radial head stability while allowing that rotation is the annular ligament.
The annular ligament is absolutely crucial. Imagine a strong, complete ring that forms 4/5 of the structure encircling the radial head. It keeps that radial head locked in place within the ulnar notch while still permitting free rotation.
And if that ligament gets stretched or injured?
The joint function is compromised immediately. You lose stability.
And this brings up a specific, common clinical scenario involving children.
Yes, the pulled elbow, or radial head subluxation. In small children whose ligaments are not yet fully mature, a sudden, sharp tug on the forearm, say, when an adult pulls them up, can cause the radial head to slip out from under that annular ligament.
Because the ligament is too loose.
The instability of the ligament is the key vulnerability there. It hasn't tightened up to its adult form yet.
We also have the quadrate ligament, which is a sort of accessory stabilizer.
It's a thin, often overlooked fibrous band that connects the neck of the radius to the ulna just below the radial notch. While it's subtle, it is important because it limits excess supination, providing essential checks and balances to the rotation.
Moving beyond the synovial joints, the radius and ulna are structurally linked along their entire length by the syndesmosis, these connective tissue structures. The most prominent is the interosseous membrane.
The interosseous membrane is a broad, thin sheet of collagenous tissue binding the interosseous borders of the 2 bones. Its functions are threefold: binding the bones together, providing extensive surface area for muscle attachment, and, critically, acting as a force transmitter.
Let's focus on that force transmission. Why is the angle of its fibers so important?
This is where the biomechanics get truly clever. The fibers of the interosseous membrane run predominantly downward and medially from the radius to the ulna.
Okay, so they're angled.
They're angled. When you push up through your hand, say, during a push-up or carrying a heavy bag, the force travels primarily through the radius at the wrist.
Right, because it's the main wrist bone.
Exactly. But because of the angle of the membrane's fibers, that compressive force is shunted proximally across the membrane, onto the ulna, and then up to the humerus. It distributes the load.
So it's a shock absorber.
It's more than that. It converts the radius, which is the hand's primary contact point, into a key element of a powerful lever system by ensuring that ulna takes a major share of the load at the elbow. It's a brilliantly designed tension belt or load-bearing cable.
That's amazing. We also have the smaller oblique cord.
Right. The oblique cord is a thin fascial band running in the opposite direction, from the ulna below the coronoid process to the radius below the tuberosity. It just provides some accessory stability, helping to maintain the spatial geometry of the 2 bones during movement.
Our final joint in this system, completing the rotational puzzle, is the distal radial ulnar joint, or the DRUJ.
The DRUJ is another uniaxial pivot joint. Here, the convex distal head of the ulna articulates within the concave ulnar notch of the radius. This joint allows the distal radius, which carries the hand, to sweep around the relatively fixed distal ulna.
And that's what we see when we pronate and supinate.
That is exactly what you see.
And the main stabilizer and buffer for this distal complex is the triangular fibrocartilage complex, the TFCC.
The TFCC is arguably the most vital soft tissue structure in the wrist for stability. It's an articular disc that attaches firmly to the ulnar notch of the radius and the base of the ulnar styloid process.
And what are its functions?
They're multiple. First, it completely separates the ulna from the carpal bones, preventing bone-on-bone articulation. Second, it acts as a shock absorber, absorbing massive compressive forces, especially on the ulnar side of the wrist.
And third?
It serves as the primary static stabilizer of the DRUJ during rotational movements. It keeps everything in place.
Considering its functions, it's not surprising that it experiences significant wear and tear.
Absolutely. We know that degeneration of the TFCC is incredibly common. It's frequently seen in individuals beginning after 50 years of age. It just reflects the high compressive and rotational stresses this small piece of fibrocartilage absorbs over a lifetime.
So it's suspended by ligaments.
It is, primarily by the dorsal and palmar radial ligaments, which are really just functional parts of the TFCC itself.
We've established the frame. Now we need to install the engine. It's time for the 20 movers, the muscles of the forearm.
The fun part.
This is where we need to switch our focus from pure description to functional insight, because listing every attachment of 20 muscles would be overwhelming. The key is understanding how they are grouped, what controls them, and why they are organized this way.
Right.
We begin with the anterior compartment, the flexor pronator group.
This group is essential for gripping, strength, and turning the hand down. The general rule for this compartment is clear. Most of the muscles are supplied by the median nerve, either directly or via its branch, the anterior interosseous nerve, or AIN.
But the exceptions are hugely important for diagnosis.
Hugely. The flexor carpi ulnaris, or FCU, and the medial half of the flexor digitorum profundus, or FDP, are ulnar nerve territory. That's a key distinction.
Let's break down the layers, focusing on their main action and that critical nerve supply. Starting with the superficial layer, mostly originating from that common flexor origin at the medial epicondyle.
First up, the pronator teres. Its action is prime pronation and weak elbow flexion. Innervation is the median nerve.
How do you test it?
It's a powerful muscle. We test it by asking you to pronate your forearm against resistance, especially with the elbow slightly extended, which maximizes its leverage.
Next, the wrist control muscles.
We have the flexor carpi radialis, or FCR, which flexes the wrist and pulls it toward the thumb side. That's radial abduction. Innervation is the median nerve. Then you have the palmaris longus, the small muscle that weakly flexes the wrist and tightens the palmar fascia.
But it's often missing, right?
That's right. It's absent in about 15 to 20% of people. A good anatomical trivia nugget, also median nerve.
And the critical exception muscle in the superficial layer, the flexor carpi ulnaris, or FCU.
The FCU's function is powerful wrist flexion and ulnar adduction, pulling the wrist toward the little finger side. This muscle is the hallmark of the ulnar nerve in the forearm.
And it has two heads.
It does, a humeral and an ulnar head, and they create that critical passageway, the cubital tunnel, for the nerve to pass through. Testing it involves resisting that combined flexion and adduction.
Okay, moving to the intermediate layer, the flexor digitorum superficialis, FDS.
The FDS is the intermediate finger flexor. Its defining action is flexing the proximal interphalangeal joints, the PIP joints.
The middle knuckle.
The middle knuckle, yes. This is vital for wrapping your fingers around an object. Innervation is the median nerve.
Now, the test for FDS is one of the most specific maneuvers in clinical anatomy, designed to isolate its function from the muscle below it.
Exactly. To isolate FDS, you must fully extend the adjacent fingers to the one being tested. If you can still flex that middle joint while holding the other fingers out straight, you've proven FDS function. That maneuver prevents the tendons of the deeper muscle, the FDP, from contributing.
Okay, now for the deep layer, the muscles of primary power grip and fine motor control.
The flexor digitorum profundus, FDP, is the true master flexor. It acts on the distal interphalangeal joints, or DIP, the joints closest to your fingertip. It also flexes the PIP, MCP, and wrist joints. This muscle is what allows you to hold a tight grip.
And here's the dual innervation insight we need to focus on. Why two nerves for one muscle?
The FDP demonstrates a clear division of labor. The medial half, which controls digits 4 and 5, is supplied by the ulnar nerve.
So the ring and the little finger.
Yes, which suggests the importance of ulnar control for the powerful part of your grip. The lateral half, for digits 2 and 3, is supplied by the anterior interosseous nerve, which is a branch of the median nerve.
The index and middle fingers.
Exactly, suggesting that these fingers, used for precision and pointing, require median nerve control. Testing is simple. You just resist flexion at that DIP joint.
The thumb specialist is next. The flexor pollicis longus, or FPL.
The FPL gives the thumb its unique gripping capability, flexing the thumb's interphalangeal joint, the last joint of the thumb. Innervation is the anterior interosseous nerve. It's essential for pinch strength.
And finally, the deepest, most distal pronator, the stabilizer of the DRUJ.
That is the pronator quadratus, or PQ. It's a flat, deep, square muscle. While the pronator teres up top is the powerful prime pronator, the PQ is the primary mover for pronation in terms of precision and sustained rotation.
And it has another job.
Crucially, it is also a key stabilizer of the distal radioulnar joint. Innervation is, again, the anterior interosseous nerve.
Okay, let's turn the arm over and look at the posterior compartment, the extensors and supinators. Their general rule is much simpler regarding innervation.
Much simpler. They are all supplied by the radial nerve, or its deep branch, the posterior interosseous nerve, or PIN. If you have a functional deficit in this compartment, it points almost exclusively to a problem with the radial nerve pathway.
We'll cover the superficial group first, starting with an unusual elbow flexor that lives with the extensors, the brachioradialis.
The brachioradialis is the functional anomaly here. Its primary action is powerful elbow flexion, but it is unique because it acts best when the forearm is in a mid-position between pronation and supination.
The beer-drinking muscle.
That's the one. Innervation is the radial nerve. Testing involves resisting elbow flexion with the forearm held in that mid-position.
Now, the true wrist extensors.
We have the extensor carpi radialis longus, ECRL, and extensor carpi radialis brevis, ECRB. Both extend the wrist and perform radial abduction. The ECRB is functionally cited as the primary wrist extensor, essential for stabilizing the wrist during gripping actions.
And their innervation.
ECRL is radial nerve supplied. ECRB is supplied by the deep branch of the radial nerve. These two, along with the brachioradialis, form the critical mobile wad of Henry on the lateral forearm, a functional unit crucial for fine control.
The remaining superficial muscles handle the fingers.
Right. The extensor digitorum, ED, extends digits 2 through 5, primarily acting on the MCP joints. The extensor digiti minimi, EDM, focuses on extending the fifth finger, allowing for independent movement of the pinky.
So you can raise your pinky.
That's the muscle for it. They both contribute to wrist extension and are innervated by the posterior interosseous nerve.
And the ulnar stabilizer for extension, the extensor carpi ulnaris, ECU.
The ECU performs wrist extension and ulnar adduction, pulling the wrist toward the pinky side. This muscle balances the radial extensors and is also supplied by the posterior interosseous nerve.
Finally, the deep group of the posterior compartment, essential for fine thumb and index finger control.
We start with the small anconeus near the elbow. Its action is to initiate elbow extension, stabilize the joint, and importantly, it pulls the synovial membrane out of the way to prevent pinching during extension. Innervation is the radial nerve.
Next, the muscle that houses a critical nerve branch, the supinator.
The supinator performs supination, turning the palm up, especially for slow, unresisted movements. This muscle is famous because the deep branch of the radial nerve must pass through it to become the pinum.
And its innervation reflects that.
It does. It's the deep branch of the radial nerve. Testing involves resisting supination with the elbow fully extended to minimize the powerful contribution of the biceps brachii.
And the fine motor specialist for the thumb and index finger.
There are 3 thumb muscles here. Abductor pollicis longus, APL, which abducts and extends the thumb at the CMC joint. Extensor pollicis longus, EPL, which extends the terminal phalanx. And extensor pollicis brevis, EPD, which extends the proximal phalanx.
And the EPL's tendon path is noteworthy.
It is. It curves around Lister's tubercle on the radius, which gives it the mechanical advantage to pull the tip of the thumb back powerfully.
And the final muscle allows us to point with precision.
That's the extensor indicis, or EI. It allows the index finger to extend independently of the other fingers, crucial for pointing and subtle manipulation. All four of these deep muscles, APL, EPL, EPB, and EI, are innervated by the posterior interosseous nerve.
20 muscles detailed by their functional contribution and their control mechanisms. This brings us seamlessly to the tracing of those crucial control wires and lifelines.
The plumbing and the wiring.
Exactly. The lifeblood of this entire muscular system originates from the termination of the brachial artery in the cubital fossa, where it bifurcates into the radial and ulnar arteries.
The critical junction point.
Let's track the radial artery pathway first.
The radial artery is the smaller of the two terminal branches. It takes a lateral course, traveling down the outside of the forearm, shielded by the brachioradialis muscle.
And it gives off branches.
Of course. Along its path in the forearm, it gives off the radial recurrent artery, which contributes to the elbow anastomoses and muscular branches, along with the palmar and dorsal carpal branches distally. It's the one you feel for your pulse at the wrist.
And where does it end up?
Its ultimate course is crucial. It passes distally, moving deep to the tendons of the thumb's extensors APL and EPB before diving into the hand to form the deep palmar arch.
Okay, so the ulnar artery is the larger terminal branch, and it takes the medial course.
It does. The ulnar artery begins by passing deep to the pronator teres muscle running down the medial side of the forearm. Its branches are substantial. The anterior and posterior ulnar recurrent arteries, both major contributors to that elbow collateral network, and various muscular branches.
And its most crucial short branch is the common interosseous artery.
The common interosseous artery springs off the ulnar artery almost immediately and is vital because it ensures the deep structures have a robust supply. It divides almost instantly into the anterior interosseous artery, AIA, and the posterior interosseous artery, PIA.
Where does the AIA go?
The AIA runs along the anterior surface of the interosseous membrane, supplying the deep flexors of the anterior compartment FPL, FTP, and PQ. It terminates by piercing the interosseous membrane near the wrist, passing deep to the pronator quadratus to join the dorsal carpal arch.
So it serves the deep front compartment and the PIA.
The PIA passes posteriorly over the interosseous membrane, supplying the deep extensor muscles of the posterior compartment. The separate, deep course of these interosseous arteries demonstrates the body's dedication to independently supplying the deep, precision-focused musculature.
We mentioned it earlier, but we need to re-emphasize the brilliance of the vascular anastomoses at the elbow.
This collateral circulation is the insurance policy. It's a dense network linking the recurrent arteries, radial, anterior, and posterior ulnar recurrent, with the collateral branches coming from the brachial and profunda brachii arteries.
And it's structurally necessary.
Absolutely. When you flex your elbow fully, the main brachial artery is momentarily compressed. If this network didn't exist, the entire forearm and hand would rapidly become ischemic. This bypass system maintains continuous flow regardless of limb position.
Switching to drainage, let's trace the venous drainage and lymphatics.
Superficial drainage is handled by the major cutaneous veins, the ones visible just under the skin. The cephalic vein runs laterally. The basilic vein runs medially. They are linked in the cubital fossa by the frequently used draw site, the median cubital vein.
And the deeper system ensures blood leaves the muscles efficiently.
Right. Deep venous drainage involves vena commitantes. These are paired veins that literally accompany the major arteries. So you have radial, ulnar, and interosseous vena commitantes. These drain into the median cubital vein and eventually flow into the brachial vein in the arm.
And the lymphatic fluid follows these pathways.
It does. The lymphatic vessels follow both the superficial and deep veins, collecting fluid and filtering it primarily through the supracochlear nodes, which are found near the medial epicondyle, and the deeper nodes that run alongside the brachial artery.
Let's conclude this section by detailing the communication pathways that control every action, starting with the median nerve, the nerve of general flexion and pronation.
The median nerve runs a central protected course down the middle of the forearm, initially passing between the two heads of the pronator teres. Its motor function is extensive.
What does it supply?
It supplies nearly all the superficial flexors, except for FCU, of course. It supplies FDS, and via the anterior interosseous nerve, or 8A, it controls FPL, pronator quadratus, and the lateral half of FDP. It's a workhorse.
Its sensory role in the forearm is minimal, though it's famous for its distal sensation.
Correct. It gives off the palmar cutaneous nerve, which supplies the skin of the palm itself, but the proximal forearm skin is supplied by other nerves. Clinically, the median nerve is prone to compression where it passes through the pronator teres muscle, and most famously, distally at the carpal tunnel.
Next, the ulnar nerve. the nerve of power grip and fine hand control.
The ulnar nerve is exposed and easily palpable as the funny bone behind the medial epicondyle. It enters the forearm by passing through the narrow cubital tunnel, which is formed by the ligamentous arch connecting the two heads of the flexor carpi ulnaris.
Another vulnerable spot.
A very vulnerable spot. This is a recurring clinical theme.
And its motor territory in the forearm is highly specialized.
It's very restricted compared to the median nerve. It only supplies the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Its primary functional impact is distal, where it supplies most of the intrinsic hand muscles necessary for precision and powerful pinching.
Our final major nerve is the radial nerve, the nerve of extension and supination.
The radial nerve divides into its two terminal branches in the cubital fossa, splitting the labor. The first is the deep branch. This branch is purely motor.
So no sensation from this one.
None. It supplies the supinator and the ECRB, and then, crucially, it winds around the neck of the radius, passing directly through the substance of the supinator muscle itself via the arcade of Fros.
That sounds like a potential trap.
A classic entrapment site. Once it emerges, it is renamed the posterior interosseous nerve, or PA, which then supplies nearly all the remaining extensors in both the superficial and deep layers.
And the second branch, traveling with the radial artery.
That's the superficial branch. It is primarily sensory. It runs down the forearm deep to the brachioradialis, accompanying the radial artery. It becomes cutaneous near the wrist, providing sensation to the dorsum, the back of the hand, and the lateral fingers.
The roadmap is now complete. We have the bones, the joints, the muscles, and the lifelines. It is time to synthesize this detailed knowledge and discuss the profound clinical implications of these precise anatomical relationships.
Yes. By understanding the tight structural relationships we've just outlined, we can predict exactly where the system is most likely to fail. The forearm and elbow provide several key predictable sites of injury and functional risk.
Let's revisit the collateral circulation at the elbow and why its anatomical redundancy is literally a matter of life or limb.
In cases of severe trauma, specifically a supracondylar fracture of the humerus, which is one of the most common childhood elbow injuries, the main brachial artery is highly vulnerable to severance or severe compression.
So the main highway is blocked.
It is. And if that happens, this collateral network must sustain blood flow to the forearm muscles. If that bypass system fails, the resulting tissue death from ischemia is rapid and irreversible. It leads directly to Volkmann's ischemic contracture.
And what is that?
And it's a permanent shortening and scarring of the flexor muscles. It means the hand and wrist are left in a permanently clawed and dysfunctional position. It's devastating.
Wow, okay. The nerve pathways also have critical pinch points. We highlighted the ulnar nerve vulnerability.
The ulnar nerve is structurally exposed in two major areas at the elbow. First, its direct posterior course behind the medial epicondyle makes it susceptible to simple external trauma. That's the funny bone sensation.
Right.
But more importantly, it is highly prone to compression as it passes through the narrow cubital tunnel formed by the two heads of the flexor carpi ulnaris. Chronic compression here, known as cubital tunnel syndrome, leads to progressive motor weakness and atrophy in the intrinsic hand muscles, resulting in sensory loss across the medial 1.5 digits.
And we see a functional mirror image of this vulnerability with the radial nerve's deep branch, leading to specific extensor weakness.
This is known as posterior interosseous nerve, or PIN entrapment. The deep branch of the radial nerve must pass through the fibrous arch of the supinator muscle, which is known as the arcade of Fros.
Another tunnel.
Another tunnel and a frequent site of compression. If the nerve is trapped here, the result is paralysis or significant weakness of the extensor muscle supplied by the PI, which often manifests as wrist drop, the inability to actively extend the wrist and fingers.
So it's a command issue.
It's a deficit of command, exactly. Not necessarily a deficit of muscle strength itself. The signal just isn't getting through.
And circling back to that architecture, we must reiterate the acute danger of compartment syndrome of the forearm.
It remains a surgical emergency because of that tight fascial wrapping we discussed at the very beginning. Any severe trauma causing muscle swelling will lead to high pressure within the compartments, rapidly compromising the vessels and nerves within.
Is one compartment more at risk?
The anterior compartment is particularly susceptible, placing the anterior interosseous nerve and artery at profound risk. This can lead to rapid functional loss of the deep flexors, FPL, FDP, and PQ.
Understanding these compartments allows us to organize muscle function into clinical groups. We discussed the mobile wad of Henry earlier.
That's a key functional concept. It encompasses the brachioradialis, ECRL, and ECRB, a powerful group on the lateral side that functions together to control elbow flexion and to stabilize the wrist in extension.
And that stabilization is key for grip.
It is absolutely essential before you can generate any meaningful grip strength. You can't grip powerfully with a flexed wrist. The extensors have to be working.
And we can summarize those crucial, highly specific testing maneuvers required to diagnose nerve injury and differentiate between muscle functions, as highlighted by the source material.
The distinction between the pronators is vital. You test the forceful proximal pronator teres by resisting pronation with the elbow extended. But to isolate the deep, stabilizing pronator quadratus, you test resisted pronation when the elbow is maximally flexed.
And why is that?
Because flexing the elbow places the pronator teres at a mechanical disadvantage, so you're really only testing the PQ.
Very clever. Similarly, the distinction between the deep and intermediate finger flexors is the gold standard for localizing median nerve branch injuries.
Absolutely. We isolate FDS function by testing only the proximal interphalangeal joint while forcing the patient to keep their distal joint straight. And we test FBP by asking for resisted distal interphalangeal joint flexion. The ability to perform one but not the other tells the clinician exactly where the damage is along the median, ulnar, or anterior interosseous nerve pathways.
We have completed a comprehensive deep dive into the elbow and forearm. What emerges is not just a dense anatomical list, but the recognition of an elegantly engineered integrated mechanical system. The sophistication of the osseous platform, the stability provided by the ulna's hinge structure perfectly complemented by the radius's rotational specialization is truly stunning.
The efficiency of the forearm is completely dependent on that stable yet mobile dual articulation. It allows for the necessary high-force stability at the humeral joint while simultaneously facilitating the complex rotation necessary for tool use and fine manipulation through the radio-ulnar joints. All of this is powered by 20 compartmentalized muscles and fueled by a beautifully redundant neurovascular system.
It's the ultimate evolutionary solution for the human hand.
It really is. And the integration of the neurovasculature, especially that detailed collateral circulation, ensures resilience. The precise segregation of function by the median, ulnar, and radial nerves is what makes possible the full spectrum of human activity, from a powerful pull-up to the most delicate thread manipulation.
As a final provocative thought for you to consider, we spent time detailing the specific ossification timings. The radius's distal epiphysis uniting late, around 20 years of age, and the ulna's olecranon joining earlier, around 14 to 16 years. This incredibly prolonged, precise developmental schedule, spanning almost 2 decades of maturation, suggests a massive biological investment. What does this long commitment to finalizing the anatomical framework tell us about the fundamental, defining evolutionary importance of the human elbow and forearm in enabling our manipulative capabilities and ultimately shaping our overall anatomical success as a species?
You are now equipped with the deepest, most functional understanding of the complex machine that is the arm you rely on every single day.
Thank you for joining us on the Deep Dive.